So ileofemoral DVT is essentially a clot in the ileofemoral region. Um, the big problem with this, and the reason why we want to look at people who have DVTs in this region, is because this is actually where we would intervene. So if you have a DVT in the lower extremity, we're not necessarily going to go and get that out. For example, if you have a DVT below the knee, odds are we're just going to put you on anticoagulation. But what we do care about is patients who have a DVT that's now gone all the way to the groin region. And that's because 90% of these people might not be working after 10 years. So it's a big problem. They suffer from what's called the post-phlebitic syndrome, where they have chronic swelling of the leg, and they will tell you the leg just gets so heavy that I cannot work. I can't stand for all those periods of time. What the patients typically present with is swelling of the leg, pain. The issue is that on the venous side, when you form a clot, it's slow to get diagnosed. And I don't know if you remember the woman who started this, like when we were beginning the presentation, we started with that video of the lady who said, I had a DVT and they didn't diagnose it for 4 or 5 weeks. I just kind of walked around. That's what happens. Everybody assumes it's not going to kill you like arterial disease where you end up losing a limb. So you don't go to the ER in this excruciating pain. What happens is you keep going back to your primary care and you say the limb is swollen, it hurts. You're usually in a younger age group and they say you pulled a muscle. And eventually somebody usually gets an ultrasound and it shows, no, in fact, you have this massive ileofemoral DVT, and that is a big problem. Essentially, this affects, now we're talking ileofemoral DVT, not DVT throughout the whole extremity, but the actual things we want to treat. This affects about 250,000 people a year. So if you have a 500-bed hospital, you should literally be seeing something like 13 of these a month, to put it in perspective. And we don't. That's the thing. And so a lot of the times we want to try to get the message out that this is a big issue and we can help. Not only that, but it could lead to a pulmonary embolism, which could kill you. So it is actually a very sought after thing that we want to treat. There is a lot of evidence that restoring blood flow for these patients to the best of our ability and getting the clot out not only prevents recurrent DVTs and the post-phlebitic syndrome, which I just told you 90% of those people don't end up working after 10 years, but there is clearly evidence that has emerged that shows that it also prevents mortality rates, okay? So there have been multiple peer review studies that show that getting out the clot is going to help make sure that patients don't have higher death rates, higher VTE, higher post-thrombotic syndrome. And if you had already done an intervention and you left clot, there's a higher incident of your stent that you put in to try to open the vein failing if you don't get the clot out. So this is a very big push by the Society of Vascular Surgery to get like awareness out about these patients. Now, of the 250,000 people who have this in America every year, only 32% of them actually get intervention. So it is a very, that's not good. That's a very poor number, right? And it is not uncommon for a vascular surgeon to see a patient and they say, well, you know, I had this ileofemoral DVT. I keep going back to the primary care. They put me on, you know, Xarelto, Eliquis, whatever, Coumadin. And I keep going back. It's not getting, like, the pain is terrible. And it's been now 3 months, 6 months. That is a very common thing in my practice. Probably happens to me every 2 or 3 clinics. There is something about the venous flow or the difference between the arterial system and the venous system that makes it why this is the case, just like I said. So if you clot off your artery, you've just knocked off blood flow to the leg and you have an ischemic leg. That is so painful. There is no way that you're not going to seek medical attention. But on the venous side, it's a low flow system. A lot of the times the symptoms the patient complain about could easily be mistaken for oh, he just pulled a muscle or something along those lines. But it is important to recognize this. the technology in treatment of ileofemoral DVT has just skyrocketed in my career. So, initially we would have just said, give the patient systemic TPA. But then it evolved into using catheters that are like a garden hose with holes punched into it, and you would stick them into the area. And I'm going to show you pictures of all this technology. And that's catheter directed lysis. Then it moved into the arena of percutaneous mechanical thrombectomy, where you use some sort of a device. And some of these have gone out of favor, but there are ones that have held steady for years, where you're trying to morcellate the clot, if you will, and then either suck it out. And now we are into the realm of extraction, like getting the clot out completely on that setting and decreasing the patient's hospital stay. And I would argue that this, and actually Dr. Garland and I would both argue that this is going to go into an area where it should just be done in an outpatient setting if you have the right technology, and you're going to see some of that. So this is the Uni-fuse catheter, a catheter that's been punched a million times and is like a garden hose, and you would just stick it there, as opposed to giving systemic TPA and just leading to possible bleeding from anywhere. Now you've put the catheter into the clot to decrease the odds of a patient having bleeding from other sites. These are some of the devices that are used, and so I'm going to mention all of them just so we don't favor one or the other in an academic setting. But these are some of the clot retrieval devices that are used to just extract or morcellate the clot. Two that are of kind of an even higher level of significance, I would argue, currently, are the CLOT Retriever device and the Penumbra device. And it's not an industry plug. It's simply that these devices are now moving into the realm of, can we get the clot out in one setting, decreasing hospital costs and danger for the patient, and essentially also avoid blood loss. And I would argue that CLOT Retriever is kind of jumping into the next realm of proving that they don't even have like minimal blood loss, like 20 cc's to 40 cc's. So the catheter over there is the Penumbra catheter. That's a Cat 8, and it has, as you can see, a wire that has like a ball on the end. And the idea is that you would move that back and forth, and it would also morcellate the clot, but it's also connected to a device that has a essentially large amount of suction. You turn it on and it will suck out the clot. The CLOUT Retriever over here is literally a basket that you put up in the IVC and slowly pull down, and it will pull out the clot. And this is a video, which I pray will work because I hate technology some days. But as you can see, the basket is coming out and it's above the clot. You can slowly pull this basket down and it will grab the clot and pull it out. And then they have a sheath that comes with it that has this basket to try to stop any of it from going anywhere else too. So it is a very impressive device. So their company has actually worked to create this CLOUT registry. The significant part of this is that they're trying to enroll essentially 500 patients, but at the last American Venous Forum, they had 105 of them. And what we noted is that they were taking patients who even might have presented after 2 weeks, may have even had multiple interventions, but 99% of patients were treated at a single session. And the median hospital stay was now 2 days. And so that's huge. Now we're starting to say we may be able to treat ileofemoral DVT in an outpatient setting. And this is an example of a patient, and we have a great example of another patient too, so I'm almost done. But this is a patient who thrombosed off her entire IVC in both legs, and we were able in one setting to remove all of that clot and discharge her. This is another, and this is another key point with this device. You're not giving them TPA anymore. So the big fear with the TPA was that we were ending up, especially when you were giving systemic TPA, you would lead to bleeds in other areas. Let's say they had a hemorrhoid, or let's say they had a cerebral aneurysm or something, you give the TPA, you risk the bleed. With this device now, you're not even giving them TPA. Similarly with penumbra, you're not. And this is a patient who came in and she had breast cancer and they wanted to perform her. She got a massive DVT and she lives in Vail. We brought her down. The breast surgeon actually came down too because she has privileges at one of the hospitals we work at. And we were able to pull all of that clot out of her extremity, not give her any TPA, and allow them to take her to breast surgery immediately after. So that's kind of the arena that clot retrieval is going into nowadays.